Going to cover quite a few different disorders involving the nose and the throat, including common cold, rhinosinusitis, epistaxis, foreign body in the nose, and allergic rhinitis. Allergic rhinitis is in a later chapter. I believe it's chapter 36. So be mindful of that as we move through. And unfortunately, our textbook includes all of the nose and throat disorders in the respiratory disorders chapter. So you're going to have to kind of look through chapters 32 and 36 to look at this. And then when we get into respiratory, it's going to be those same chapters because asthma is also in chapter 36. So be mindful of what we're talking about and make note of where it is in your textbook. So first is the common cold or upper respiratory infection. It's usually viral, caused by hundreds of different viruses. Very common in children. It's spread by aerosols. So it is most common in preschool and daycare attendees because it spreads like wildfire, especially in young children. They tend to put things in and near their mouth a lot. So germs spread very quickly. It's usually self-limiting. On average, lasts about 7 days, but it can last up to 2 weeks. You don't want to treat this. It's supportive care only. Motrin, ibuprofen for fever, pain, aches, warm liquids for the sore throat. The biggest complaints they're going to have is rhinorrhea, maybe a cough, sore throat. A key finding is rhinorrhea, where they have drainage from the nose. They may have a stuffy nose. We all know what the symptoms of an upper respiratory infection are. Most common complication are bacterial infections secondary to the viral infection, such as otitis media that you get after you have a cold. One thing you do not want to give these patients is antibiotics because you're not doing any good. You're creating more resistance. So you only give antibiotics if they have a secondary bacterial infection. If you look on page 511, table 32.3, there's a table of differentiations of common respiratory infections in children. I just want you to kind of review that. We're going to go over. We just did the common cold, and then rhinosinusitis will also be covered in this. So that table is really good for you to review. We'll discuss rhinosinusitis. This is just inflammation of the sinuses and adjacent nasal mucosa. It can be infectious, but it's not always infection. Okay. Only about 2% of colds are complicated by sinusitis. You can have either acute or chronic. Acute is inflammation of the mucosal lining of the nasal passages and paranasal sinuses. Acute bacterial sinusitis is a complication of a viral URI or common cold. Sinusitis results because of different anatomic factors can be present. It usually presents in 3 ways. You have onset of severe upper respiratory symptoms, onset of upper respiratory symptoms with persistent symptoms, and a double sickening with initial improvement followed by onset of severe disease. Chronic rhinosinusitis is diagnosed when symptoms persist for 12 weeks or longer. So if you have a patient that you diagnose with sinusitis and 3 months later they still have it, we've moved into chronic, and the treatment is going to change in that. Most common pathogens are strep pneumonia, Haemophilus influenza, and Moraxella catarrhalis. That's important to know. You need to know what you're treating because different antibiotics cover different diagnoses. The adenoids are believed to be a reservoir for bacterial infection that leads to nasal sinus infections, and that's why people that have chronic inner ear infections, etc., end up with an adenoidectomy. Okay, if you look on page 511, table 32.3, it breaks down the common cold, but it also breaks down acute rhinosinusitis, subacute, and chronic or recurrent sinusitis. So I want you to know that table because it tells you what you're going to use to treat. Okay. Acute sinusitis usually lasts 10 to 30 days. You're going to use Amoxil or Augmentin for 10 days. By 7 days, they should be asymptomatic. You want to change the antibiotics 48 to 72 hours after they start the initial antibiotics if there's no response to the treatment. Okay. It also tells you the symptoms. Acute sinusitis usually has persistent nasal symptoms for more than 10 days with the common cold. They have nasal drainage and cough. They may or may not have low-grade fever and rhinitis. Subacute rhinosinusitis is the same, but it lasts at least 30 days. So between 30 and 84 days is what you're going to call subacute sinusitis. Again, you're going to do Augmentin because of how long it's lasted. And that's usually when you're going to change your treatment from, if you put them on amoxicillin the first time, it's continued on. So now we're going to change them to Augmentin. And then we go into chronic or recurrent sinusitis. That the symptoms are worse. They get malaise, fatigue, nasal discharge, nasal obstruction, and then you're going to use either Augmentin or azithromycin. You need some staph coverage when we move to this point. They may need sinus surgery if it lasts. And most of these people are requiring antibiotic treatment for 3 to 6 weeks, if not longer. Likely once it's moved to the chronic sinusitis state, you're going to refer to ENT. Okay. But it's very important for you to know how to distinguish between acute and chronic. If it's lasted more than 12 weeks, we've moved into the chronic into the chronic stage. Page 512 starts the management. It's very important to know when and what to treat. Box 32.2 gives you the criteria for bacterial sinusitis. The major criteria is going to be the most important, of course, the facial pain and pressure, congestion, nasal discharge, loss of smell is another issue you may have, fever. I kind of went through some of the treatment on there. Education is very important, frequent hand washing, flu vaccine, etc. All right, so next is nosebleeds. This starts on page 522 in your textbook. Usually originates at the Kieselbach's plexus in the anterior septum of the nose. Very important to know that. Common causes, they've stuck their finger or something else into their nose and have caused trauma, dry air, inflammation, and some people have a genetic predisposition for nosebleeds. Symptoms, obviously, bleeding from one or both nares, or if it drains down the back of their throat and they swallow it, a lot of times they'll vomit the blood also. So you want to use cold compresses, hold chin up, tilt it forward. A lot of people want to immediately tilt their head back. You don't want to do that. You want the blood to come out and stop it bleeding there. Okay. Afrin can help. Vaseline during winter months, humidifiers in their room to prevent the dryness and the bleeding. So we talked about foreign bodies in the ears. Kids like to stick things in their ears and nose. So you may see it. And if it gets stuck there and they're not able to get it out and they don't say anything, if it stays there long enough, they're going to develop purulent discharge, pain on whichever side that they have the object stuck in there. You want to remove the object. You only remove it if the child is cooperative, and you can use the forceps. If it's hard and they're fighting you, they can't do anything, you need to refer, and sometimes they have to be taken to surgery and put under anesthesia. Okay. If it's something that is dangerous to remove, like a paper clip, a staple, something with a sharp end, you don't want to try to remove it. Send them to ENT and let them remove it. And a lot of times they will have to use some type of anesthesia to do that. Okay, so next we're going to talk about allergic rhinitis. Again, this is in chapter 36. It starts on page 678. It is located in the respiratory chapter. In the inflammatory disorders chapter. And basically, allergic rhinitis is a disorder that results in nasal mucosa inflammation. It is an atopic or allergic reaction. Something causes a release of chemical mediators, and antigen-antibody reaction results in inflammation of the nasal epithelium. You're going to diagnose this based on symptoms: rhinorrhea, nasal pruritus, nasal congestion, sneezing. It's usually seasonal, perennial, or episodic. It is the second most common atopic disorder. The first is asthma. It's rare in children less than 2 years of age. There's multiple types. You can have seasonal, which includes hay fever, airborne allergies to pollen, grass, trees, weeds. Typically occurs after 3 years of age. Then you have perennial, where they have year-round signs and symptoms, but it's more severe in the winter. Onset can occur before the age of 2 in perennial. This also covers the indoor allergens: dust mites, cockroaches, feathers, pets, mold, seasonal pollens, etc. Or they can have episodic, where they're exposed intermittently to a specific allergen, usually related to a distinct or specific event. It can also range from very mild to very severe. I'm not going to go into all the different immunoglobulins that are affected and how the allergic reaction happens. You can read through that if you'd like on pages 678, 679. We're more concerned with how are you going to diagnose it and how are you going to treat it. Some of the other symptoms or findings on physical exam are going to be nasal obstruction, which we already said, nasal congestion. They may mouth breathe. They may, or whoever sleeps near them may say that they snore. They may sound nasally when they talk. They may have clear, thin, watery rhinorrhea, where they're just draining clear. It's not purulent. It's not thick colored. It's watery. Itching, rubbing up the nose. Allergic shiners, Denny lines can happen. They can have sniffling, snorting, coughing, frequent attempts to clear their throat because things are draining down the back of their throat. They can have redness of the conjunctiva. They can have increased tearing. All the things that go along with allergies and allergic reactions. They can have cobblestone appearance of the pharynx and palpebral conjunctiva. Chronic mouth breathing, of course, sleep disturbances because they're not able to breathe well enough when they're sleeping. Allergy testing is something that can happen, and you can send them to an allergist for allergy testing. We've already discussed the clinical findings. Management, of course, number one is avoidance of triggers. Things that parents, caregivers, whoever they live with can do is use dust mite proof mattress protectors, pillow covers, wash linens in hot water very frequently. If they're only washing their linens, their sheets and comforters every month, they need to do that much more often. Minimize stuffed animals and toys, because anything that's soft like that tends to harbor those allergens. Remove carpet if possible. Limit upholstered furniture. You can do immunotherapy. Obviously, that's probably not something you're going to do in a family practice clinic, but it is possible. Education is very, very important. If you prescribe inhalers or nasal sprays, you need to give detailed instructions on how to use those things. Treatment, obviously, is going to depend on the severity, but antihistamines are first line: Benadryl, hydroxyzine, Claritin, Zyrtec, Allegra. Zyrtec, Claritin, and Allegra are usually associated with less less sedation, but they can still be sedating. Intranasal corticosteroids and montelukast can be used. If you look starting on page 681, it talks about the pharmacological treatment of allergic rhinitis. And then on page 683, table 36.11 goes into the different classes of antihistamines and some side effects that it can cause. Again, it does list loratadine, Zyrtec, Allegra as non-sedating, but it can cause sedation. You need to be mindful of using loratadine in children under 2 years of age. It's not recommended for them. Zyrtec is for children older than 6 months. Allegra is approved for children older than 6 months for chronic urticaria and over 2 years of age for allergic rhinitis. So again, remember that. Then it goes into table 36.12, which is the intranasal corticosteroids, and it tells you what each can be used for. Unfortunately, a lot of them are for older children, not younger children. So if you have somebody that's 2, 3, 4 years of age, you're probably going to use your Veramist, the mometasone, and triamcinolone or Nasacort AQ. The others are for older kids. I do want you to know the names of them. I'm not going to ask you exactly, you have a patient that's 3 years of age, what dose and all of that. You just need to know the classes of medication. So your Flonase, Veramist, triamcinolone, etc. Again, your book goes through the immunotherapies. You're probably not going to do that in a family practice or primary care clinic, and that's what we are training you to do is primary care. So you're likely not going to do that. Your biggest thing is going to be educating on reducing and avoiding allergen exposure. So we're going to move back into chapter 32 to discuss pharyngitis, tonsillitis, and tonsillopharyngitis. Pharyngitis is basically just inflammation of the mucosa lining of the throat, causes it red, causes erythema, exudate, ulceration. It's most commonly caused by a virus. Adenovirus is most common in nasopharyngitis. Bacterial pharyngitis includes strep, diphtheria, gonorrhea, and pneumonia. A rapid strep test is usually how you diagnose it, and you do a CBC if mono is suspected. If nasal symptoms are present, that's when you call it nasopharyngitis. But if there are no nasal symptoms such as stuffiness, congestion, rhinorrhea, etc., then it's just pharyngitis or tonsillopharyngitis. Clinical findings: pretty much all pharyngitis patients are going to have pain, myalgia, arthralgia, fever, sore throat, dysphagia because of the sore throat. If it's viral, they may also have rhinitis, cough, hoarseness, stomatitis, stridor, conjunctivitis, a rash, and diarrhea. If it's caused by a group A beta hemolytic strep or bacterial, they're going to be that's going to be most common in 5 to 15-year-olds and very infrequent in children less than 3 years of age, but they're going to have abrupt and acute onset without nasal symptoms. They're going to have tender lymph nodes, constitutional symptoms such as arthralgia, myalgia, headache. They can have a moderate to high fever, prominent sore throat, nausea, abdominal discomfort, vomiting, headache. Usually they have no nasal symptoms, no rhinorrhea, they have no cough. You'll see petechia on the soft palate and pharynx. Their uvula will be red and swollen, and they'll also have enlarged tonsillopharyngeal tissue. The big thing to note the difference between the viral pharyngitis and bacterial is the abdominal symptoms. People with bacterial pharyngitis are going to have more of that nausea, vomiting, and people with viral are going to have less of that. The most common viral pathogens are your adenovirus, coronavirus, enterovirus, rhinovirus, RSV, and Epstein-Barr. Again, they're going to have the sore throat, fever, myalgia, rhinitis, etc. They may have a postnasal sinus drip, so they're constantly clearing their throat. One thing to note, if they have mono or you suspect mono, a lot of times they'll have a grayish appearance to their tonsils and a grayish colored exudate from the tonsils. Okay. Viral is going to be supportive care, hydration, warm liquids, etc. You're not treating that with antibiotics if it's viral. You're going to do supportive care and let it run its course. Okay. Next is bacterial pharyngitis. It's uncommon before 2 years of age. I already said that, but then it peaks in early school age because now they're being exposed to a lot more than they were before. Most commonly caused by group A beta hemolytic strep. Again, I already talked about the symptoms associated with it. You're going to diagnose this with a rapid stress test, strep test, not a stress test. Treatment is going to be antibiotics. Penicillin is the #1 treatment, first line treatment. It's been shown that antibiotics reduce the length of the fever, decrease infectivity, it lowers toxicity. It's also based on positive bacterial testing results in the symptomatic patient. So you're going to start with penicillin, amoxicillin. If they're allergic to penicillin, then you're going to move to cephalexin, cefadroxil, clindamycin, azithromycin. You do need to know doses and how long you're going to treat. So if we talk first line, we do penicillin V. That's going to be 250 milligrams twice a day, three times a day for 10 days. Older children and adolescents can be 500 milligrams twice a day or 3 times a day for 10 days. Amoxicillin, the suspension is more palatable than the penicillin. Another thing to note with Amoxil is they usually put in the bubblegum flavor. Kids tend to like that. And then you move to the cephalexin, which is going to be 20 milligrams per kilogram twice a day for 10 days if they're allergic to penicillin. Okay. Supportive care, still, you're going to do ibuprofen, Motrin, fluids, rest, etc. That's about all they need to do. If with any type of pharyngitis, they need to get rid of toothbrushes, cups, anything that they used before. If they have any type of orthodontic device, it needs to be very, very sanitized before they start using it again, or you're just going to keep with reoccurrent strep. Okay. They can return to school when they are afebrile and have been taking antibiotics for 24 hours. Most schools are going to tell you they cannot come back until 24 hours without fever. Okay. And that's without medicated fever. So if you're giving them Tylenol, Motrin, and that's bringing the fever down, that doesn't count in the 24 hours. They need to have a fever, no fever without medication for 24 hours. Okay. If you're going into chronic symptomatic strep, you're going to use clindamycin, augmentin, penicillin V for 10 days. That's important to note. Complications of strep include rheumatic fever, post-strep reactive arthritis, and acute glomerulonephritis. So you need to treat it. We don't want kids walking around with strep time after time and developing some type of arthritis or worse. So it needs to be treated appropriately.